Welcome back everyone. Common cold in children is my today's lesson. So let me start from introduction. The common cold is an acute viral infection of the upper respiratory tract in which the symptoms of rhinorrhea and nasal obstructions are prominent. Systemic symptoms and the signs such as headache, myalgia, fever are absent or mild, and the common cold is frequently referred to as infectious rhinitis, but may also include self-limited involvement of the sinus mucosa and is more correctly termed rhinosinusitis. Young children have an average of 6 to 8 colds per year, but 10 to 50% of children, or those who are unlucky, might have up to 12 infections per year. The incidence of the illness decreases with increasing age, with 2 to 3 illness per year by adulthood. And the incidence of infection is primarily a function of exposure to the virus. When we see the etiologies of common cold, rhinovirus are associated with more than 50% of colds in adults and children. And in young children, other viral etiologies of common cold include respiratory syncytial virus, human metapneumovirus, parainfluenza virus, adenovirus, and also common cold symptoms can also be caused by influenza virus, non-polio enterovirus, human coronavirus, and the others. Many viruses that cause rhinitis are also associated with other symptoms and the signs such as cough, wheezing, and fever. The host immune system is responsible for most cold symptoms rather than the direct damage to the respiratory tract, and infected cells release cytokines such as interleukin 8 that attracts polymorphonicular cells into the nasal submucosa and epithelium. Human rhinovirus also increases vascular permeability in the nasal submucosa, releasing albumin and bradykinin, which may contribute to the symptoms. When we see the clinical manifestation, symptoms of common cold vary by age and the virus. Infants have fever and the nasal discharge might predominate, and the fever is uncommon in older children and adults. The onset of common cold symptoms typically occurs 1 to 3 days after viral infection, and the first symptoms noted is often sore or scratchy throats, followed closely by nasal obstruction and rhinorrhea. The sore throat usually resolves quickly, and by the second and the third day of illness, nasal symptoms predominate. Cough is associated with 2/3 of colds in children, and usually begins after the onset of the nasal symptoms. Cough may persist for an additional 1 to 2 weeks after resolution of other symptoms. The usual cold persists for approximately one week, and also 10% lasts for up to 10 weeks. And also sometimes headache, hoarseness, irritability, difficult sleeping, and a decreased appetite can be seen. And in some children, vomiting and diarrhea can also be seen. The physical findings of a common cold are limited to the upper respiratory tract, and increased nasal secretion is usually obvious, and a change in the color or consistency of the secretion is common during the course of the illness and does not indicate sinusitis or bacterial superinfection, but it might indicate accumulation of polymorphonicular cells. So increased nasal secretion or change in the color of the nasal secretion or change in the consistency of the secretion is not a sign of bacterial superinfection. Rather, it shows a common cold with polymorphonicular cells. So this is very important because some people may consider as if there is bacterial superinfection when there is increased nasal secretion, or when the nasal secretion consistency changes, or when the color changes. But this is not a sign of superinfection, rather it's a sign of accumulation of polymorphonicular cells in the nose. And the examination of the nasal cavity might reveal swollen, erythematous nasal turbinates, although this finding is non-specific and of limited diagnostic value. Anterior cervical lymphadenopathy or conjunctival injection may also be noted on exam. When we see the laboratory findings in patients with common cold, routine laboratory studies are not helpful for the diagnosis and the management of the common cold. A nasal smear for eosinophils or Hansel stains may be useful for allergic rhinitis if we suspect allergic rhinitis as a differential diagnosis. And also predominance of polymorphonicular cells in the nasal secretion is characteristics of uncomplicated colds, and it does not indicate bacterial superinfection as we have said. Self-limited radiographic abnormalities of the paranasal sinus are common during uncomplicated colds, but imaging is not indicated for most children with simple rhinitis. The viral pathogens associated with common cold can be detected by the PCR, culture, antigen detection, or serologic methods. When we see the diagnosis of common cold is clinical, and the most important task of the physician caring for a patient with a cold is to exclude other conditions that are potentially more serious or treatable. So the differential diagnosis of common cold include non-infectious disorder and other upper respiratory tract infections. Those are the differential diagnosis for common colds. Allergic rhinitis is one and the top on the list. If the cause of the upper respiratory tract symptom is due to allergic rhinitis, it is associated with more prominent itching and sneezing, and nasal eosinophilia or Hansel stains can aid the diagnosis. And also the patient have other allergic signs such as asthma, allergic dermatitis, and the like. Sometimes also vasomotor rhinitis may be triggered by rhinitis, weather changes, or spicy foods. And rhinitis pigmentosa, that means rhinitis that is caused by overuse of nasal decongestants. So drug or nasal decongestants themselves can cause rhinitis if we use them excessively. Foreign body causes unilateral foul smelling and bloody secretion sometimes. So there are multiple differential diagnoses for common cold, but we should have to differentiate them clinically. The other one is sinusitis, for example. Sinusitis, there is a fever, high-grade fever, headache or facial pain, periorbital edema, or persistence of rhinitis or cough for more than 10 to 14 days suggests super infected common cold or bacterial sinusitis, because most common cold lasts for 1 to 2 weeks. If they last more than 10 days, it shows there is a secondary bacterial infection or bacterial sinusitis. When we see the treatment of a common cold, the management of common cold is it consists primarily of supportive care and anticipatory guidance and antiviral treatment. There is no specific antiviral therapy for human rhinovirus infection, and the ribavirin, which is approved for treatment of severe RSV infection, has no role in the treatment of the common cold. The neuraminidase inhibitors, zanamivir, have a modest effect on the duration of symptoms associated with influenza viral infection in children. Oseltamivir also reduces the frequency of influenza-associated otitis media. The difficulty of distinguishing influenza from other common cold pathogens and the necessity that therapy might be started early in the illness, that means we should have to start within 48 hours of onset to be beneficial, are practical limitation to use of these agents for mild upper respiratory tract infection. So, antiviral therapies not needed in a patient with a common cold. And also antibacterial therapies of no benefit in the treatment of common cold, and it should be avoided to minimize possible adverse effects in the development of antibiotic resistance. So overall, the management of common cold is supportive. When we say supportive, the first one is maintaining adequate hydration. And the second one is topical nasal saline. Nasal saline irrigation may temporarily remove the secretions, and it opens their upper respiratory passage. Because children up to the age of 1 year, they are obligate nasal breathers, we should have to keep their nostril patent by topical nasal saline irrigation. Certain studies shows that zinc given as oral lozenges to previously LG patients reduce the duration, but they doesn't change the severity of the symptoms of a common cold if begin within 24 hours of symptoms. The functions of the effect of zinc on the symptom has been inconsistent, with some studies reporting dramatic treatment effects, whereas other studies find no benefit. And side effects are common, and they include decreased taste and body taste, and also nausea. Non-steroidal anti-inflammatory drugs, they are used to decrease discomfort, or if there is low-grade fever, they may be used to decrease the fever or to decrease discomfort. But children with a common cold do not have, most of the time, they do not have high-grade fever, but they can have discomfort. So non-steroidal anti-inflammatory drugs used to decrease the discomfort. The other treatment, supportive treatment, is use of topical or oral adrenergic agents for decreasing the congestion. Effective topical adrenergic agents such as xylometazoline, oxymetazoline, or phenylephrine are available as either intranasal drops or nasal sprays, and reduced strength formulation of these medications are available for use in young children, although they are not recommended for use in children younger than 6 years of age. Systemic absorptions of imidazolines, or that means xylometazoline or oxymetazoline, have very rarely been associated with bradycardia, hypotension, or coma. And prolonged use of these topical adrenergic agents should be avoided to prevent the development of rhinitis pigmentosa. That means an apparent rebound effect that causes the sensation of nasal obstruction when the drug is discontinued. So the main side effect of xylometazoline or oxymetazoline are the development of rhinitis pigmentosa. Using more than 5 days causes rebound effect. They themselves cause rhinitis. The oral adrenergic agents are less effective than the topical preparation, and they are occasionally associated with systemic effects such as CNS stimulation, hypertension, and palpitation. The other is the first generation antihistamine may reduce the rhinorrhea by 25 to 30%. The effect of the antihistamine on rhinorrhea appears to be related to the anticholinergic rather than the antihistaminic property of these drugs. And therefore, the second generation or non-sedating antihistamines have no effect on a common cold symptoms. That means the first generation antihistamine have anticholinergic effect, so they decrease the congestion. For example, diphenhydramine. Whereas the second generation non-sedating antihistamines, they do not have anticholinergic effect, so they do not decrease the symptoms of rhinorrhea. So diphenhydramine can be used, but second generation antihistamine like cetirizine or loratadine is not useful. The major adverse effects associated with the use of antihistamines are sedation or paradoxical hyperactivity. Overdose may be associated with respiratory depression or hallucination. The other is honey. Honey, 5 to 10 ml in children greater than 1 year of age, has a modest effect on relieving nocturnal cough. When we treat a child with common cold, we should have to remember those three things. The first one is honey should not be given in children younger than 1 year of age because of the risk of botulism. So giving honey to a children less than 1 year is contraindicated. The second one is prolonged use of topical adrenergic agents such as xylometazoline or oxymetazoline should be avoided to prevent the development of rhinitis pigmentosa. The third one is aspirin should not be given to children with respiratory infection because of the risk of Reye syndrome in children with influenza. So we can use non-steroidal anti-inflammatory drugs such as ibuprofen, and giving aspirin for a child with upper respiratory tract infection or influenza is not recommended because of the risk of developing Reye syndrome. So we should not forget those three things. When we see the complication of a common cold, the most common complications of a cold is acute otitis media, which might be indicated by new onset of fever and earache after the first few days of cold symptoms. And acute otitis media is reported in 5 to 30% of children who have a cold, with the highest incidence occurring in young infants and in children cared for in a group daycare settings. Symptomatic treatment of the common cold symptoms has no effect on the subsequent development of acute otitis media. Another complication of common cold is sinusitis. Sinusitis is another complication of common cold, and the self-limited sinus inflammation is a part of pathophysiology of the common cold. But up to 2% of viral upper respiratory tract infection in adults and up to 5 to 30% of viral upper respiratory tract infection in children are complicated with acute bacterial sinusitis. The differentiation of common cold symptoms from bacterial sinusitis might be difficult, and the diagnosis of bacterial sinusitis should be considered if runny nose or rhinorrhea or daytime cough persists without improvement for at least 10 to 40 days. That means because we expect improvement or resolution of common cold symptoms at 10 days, but if the symptoms of runny nose or cough persists for more than 10 days, we should have to suspect acute bacterial sinusitis. And also, if acute symptoms worsens over time, or if acute signs of more severe sinus involvement such as fever, facial pain, or facial swelling develops, we should have to think of bacterial superinfection. There is no evidence that symptomatic treatment of common cold alters the frequency of development of bacterial sinusitis, and bacterial pneumonia is an uncommon complication of common cold. The other is exacerbation of asthma. Exacerbation of asthma is a potential serious complication of colds, and the majority of asthma exacerbation in children are associated with a common cold virus, and there is no evidence that treatment of common cold symptoms prevents this complication. However, studies are underway in patients with underlying asthma to determine effectiveness of preventive or acute treatments at the onset of upper respiratory tract infection symptoms. The other thing is about the prevention of common cold. Chemoprophylaxis or immunoprophylaxis are generally not available for the common cold, and immunization or chemoprophylaxis against influenza can prevent colds caused by this pathogen, but influenza is responsible for only a small proportion of all colds. Palivizumab is recommended to prevent RSV lower respiratory tract infection in high-risk groups, but does not prevent upper respiratory infection from the virus. Some says vitamin C, garlic, or others prevents common cold, but this studies does not show that vitamin C or garlic or any other do not prevent common cold. Vitamin C prophylaxis might shorten the duration of the cold symptoms, and the vitamin D deficiency is associated with increased risk of viral respiratory tract infection in some studies. Nonetheless, vitamin D prophylaxis does not reduce the incidence or severity of the common cold in adults, and still in children are lacking. Zinc sulfate taken for a minimum of 5 months may reduce the rate of cold development. However, imagine taking zinc for 5 months to prevent cold symptoms. This is horrible. So, and also in addition, zinc have bad taste and nausea. This is not recommended prevention modality in children anymore. The other and the most important one is hand-to-hand transmission of human rhinovirus followed by self-inoculation may be prevented by frequent hand washing and avoiding touching one's mouth, nose, and eyes. And some studies report the use of alcohol-based hand sanitizers and varicidal hand treatment were associated with decreased transmission. Varicidal disinfectants or varicidal impregnated tissue also reduce transmission of cold virus, and under natural condition, none of these interventions prevent common cold. So the most important thing is hand-to-hand transmission should be prevented by frequent hand washing and also avoiding self-inoculation by touching our eyes, mouth, and the nose without hand washing. This is all about common cold. Thank you. Don't forget to subscribe to the channel.